Right. So this talk is about chronic diarrhea, and now you would have had lectures on acute diarrheas, right? And you'd have found that most of them are actually infective. So this is chronic diarrhea, and generally, if it's going on for over 4 weeks, right, we consider it as a chronic diarrhea. Now, you know that the number of stools that a normal person has also varies, right? The number of stools that a normal person has also varies, right? From uh, from more than from about 3 stools a day to about 2 stools a week. So normal person also, right? So there are some normal people who might go up to about 3 times a day, and there are some who go only about twice a week, and this would have been told to you in the lecture on constipation. So generally, if, to call it a diarrhea, person should have more than 3 stools per day, right? And then they should be loose stools. Now, when it comes to uh, infective, now there are many causes, right? There are many causes of chronic diarrheas. Now, as I told you earlier, most of the infective diarrheas don't last for so long, right? They are over within about 1 week usually, right? But there are certain chronic infections which can go on, especially if they are not treated properly, right? So one such infection is amoebiasis, right? So amoebiasis, right, or amoebic dysentery as it is called, can go on for some time. The other one is giardiasis, right? The other one is giardiasis. But nowadays, with the free available of antibiotics, I mean, antibiotics being available quite freely, usually it's unusual to have a diarrhea like this going on for a long period of time. And you know that for both these diarrheas, the drug of for both these infections, the drug of choice would be metronidazole, right? Because these are because basically these are parasites, right? They are not anaerobes, right? But metronidazole is effective against anaerobes, and it is also effective against these parasitic diarrheas. Then we have inflammatory bowel disease, right? That is what we usually refer to as inflammatory bowel disease are ulcerative colitis and Crohn's disease, right? And then you also have tuberculosis, right, which can also very occasionally, right, present with a diarrhea, but it's certainly not a common presentation. Then we have functional disorders like irritable bowel syndrome. So we talk a bit about IBS because this won't be covered. Now you will be having lectures on inflammatory bowel disease, and what I tell you today about inflammatory bowel disease would overlap with, what you would have been told in some of the other lectures, right? But IBS, we don't have a separate lecture, and it's a very common condition, right? It is that about 20 to 30% of the population, right, will have it at some point, right, in their lives, but it's usually common in younger people. So in this, you get chronic intermittent changes in the defecation pattern associated with pain or discomfort, right? The classical story is people who are a person who is, fairly nervous, anxious, right? Who in the morning will get up, and then after a while he will want to go to the toilet and he'll have a loose stool. Then after a little while, right, he may want to go again, right? And especially, even after he dresses up to go to work or school or medical school or whatever, right? He again would want to go back again to the toilet. So this is the kind of picture that these people have commonly. So it's usually diarrhea predominant, but you can also have constipation predominant IBS. Right? Some people are sort of, they have IBS, but their predominant problem is constipation. An important thing to know about irritable bowel syndrome is that unlike the other conditions that we mentioned, like ulcerative colitis, Crohn's disease, EB, and also malignancies and polyps and so on, which we have talked about earlier, This irritable bowel syndrome can never bleed because you see there is no mucosa, right, in these patients. Even if you do a biopsy, right, it looks perfectly normal. Okay, so it's purely a functional problem in the large bowel, right? It's the function that is affected. The large bowel becomes spastic, right? So it keeps contracting more frequently, and that is why patient gets an urge to defecate, right? And often a left iliac fossa pain, because you know that the sigmoid colon is in the left iliac fossa, right? That's the and uh, and the rectosigmoid region, right? That is all in the left iliac fossa. And then patient gets that feeling of contraction, and then he runs to the toilet, right? And then he passes a loose stool. So that is the usual story, right? And uh, there are various criteria, right, to define. Now, say supposing some person is having this for about 2 or 3 days, right, or let's say for about 1 or 2 weeks, we don't call it irritable bowel syndrome, right? That's more like a functional bowel disorder. But if it is going on for more than 3 months only, right, if patient is having symptoms for more than 3 months only, we refer to it as irritable bowel syndrome, right? So once every few years, the gastroenterologists, they meet in Rome, right, and they define various criteria to diagnose IBS and also the different forms of IBS like diarrhea predominant, constipation predominant, and so on, right? So you have what are called Rome criteria for IBS, right? But you don't have to know this because it is very complicated, and they classify this not for adults and then for children separately. Okay? So, this is kind of person, right, who has IBS. You find that, is a quite an anxious person. We've seen this among medical students also, right? And, the person sits in the toilet and actually spends quite a lot of time in the toilet and also keeps repeatedly going to the toilet, especially in the mornings. Now, if you look at the etiology of IBS, there is a thing called post-infective IBS. Let us say that somebody gets a very severe acute gastroenteritis, acute severe gastroenteritis. Then after that episode, the bowel can remain irritable for up to about 1 year, right? So they can go on having these symptoms, right, for about a year. Then of course you have the IBS, which is stress related, right? Where the person, has a lot of stress, right? And there is a relationship between the brain and the gut, right? So therefore, they find that the stress is the main factor. There are also people who have food allergies, various food allergies or intolerance to various food types of food. And one of the commoner ones is lactose intolerance, right? So sometimes you find the IBS, right, is associated with lactose intolerance. This again is a picture of, somebody, a kind of an anxious individual, right, who is having this problem. And sometimes as the patient, walks into the clinic, right, you can see and you sometimes suspect, even before you talk to the patient, right, that this patient may be having some kind of a functional bowel disorder. Now, the diagnosis of this condition is clinical, right? I told you the symptomatology. You need to talk to the patient, right? Find out exactly what the problem is, what time of the day he has these loose motions and so on, right? Not to say that it cannot occur at other times of the day, but it's more common in the mornings, right? And so you need to basically talk to the patient and get that information, right? On examination, you will not find anything except in some patients, they have a little tenderness in the left iliac fossa, right? But generally on examination, you won't find anything. Now, if the patient is over the age of about 40 years, you don't know. I mean, this could be IBS, right? But this could also be something like a colorectal carcinoma because, as you know, all colorectal carcinomas do not bleed, right? IBS, of course, never bleeds, right? But so it may be, some other pathology, right? So generally what we would do is do a colonoscopy to exclude other pathologies, right? If you don't have colonoscopy, you might be able to do a barium enema, right? And the main purpose of doing this is to exclude colitis or a malignancy, right? And sometimes during these procedures, you find that there is a thing, you find that the colon is spastic, right? Of course, it's a very subjective assessment, right? But when you're doing the colonoscopy, you find that the colon is contracting quite forcefully, right? It's contracting forcefully. Now, the other thing is that sometimes in these patients who complain of diarrhea, right, we also take biopsies from the colon, right? The reason is there is this condition called microscopic colitis, right? There are various forms of colitis, right, which can't be seen when you do the colonoscopy, but there are changes which you can see on histology, right? So people talk of microscopic colitis, collagenous colitis, lymphocytic colitis, and so on, right? There are different forms of colitis. So you can take biopsies. Only thing is for these conditions that I mentioned, there is no specific treatment, right? It's almost like treating IBS, right? You treat it, like an IBS because there is no sort of specific treatment. So how do we treat IBS? Now, the treatment of IBS is multifaceted. There isn't sort of one wonder drug, right, that you can use for treatment of IBS, like you're going to treat amoeba with metronidazole or something like that. Okay, so it is multifaceted, multidisciplinary. It's important to talk to the patient and educate them, and especially if you have excluded other sinister causes like malignancy, colitis, and so on, you can tell the patient that they don't have anything serious, right? And need to educate them about this condition. Then you need to talk diet, right? Sometimes from the patient's history alone, you can clues. When I eat pork or whatever meat, or I get it, right? And then you tell him to avoid that kind of food. So basically, you need to take a fairly detailed dietary history, right? You need to take a fairly detailed dietary history on these patients, right? And find out what food offends them, right? So in general, right, things like meat products, right? Some people have a problem with eggs. Then of course, if they're having lactose intolerance, milk, right? So basically, and also oil, right? Very oily food, right? These things tend to worsen it, right? So you need to talk to the patient, discuss, and see whether you can sort it out. Now, I told you very often this diarrhea predominant, the common type of IBS that you get is associated with spasms of the bowel, right? So there are various antispasmodics, right? The oldest one that was used was propantholene bromide, right? But now we don't use it so much because of the side effects, right? Like dry mouth and things like that. So because of that, the common ones that are used, right, are hyoscine, right? Hyoscine butyl bromide, right? Which is comes under a trade name, right? Hyoscine or mebaverine, right? Mebaverine is more effective than hyoscine. And you can also use both these drugs together because they have different modes of action, right? So therefore, these two drugs, right, are the ones that are commonly used. And this mebaverine, you have the normal mebaverine that is 135 milligrams 3 times a day, right? Or you also have a long-acting one, which is 200 milligrams twice a day, right? Comes in different brands. The important thing, if you're giving these drugs, is to give it about half an hour before the meal, right? Because once they start eating, the bowel starts going into spasm. Another feature that these patients have is that they need to go to the toilet immediately after meal, sometimes even during the meal. Okay, right? So that is another feature, right, that these patients have. Now, if this doesn't work, right, and the diarrhea continues, right, and you have excluded other causes, then we go in for anti-diarrheal drugs, right? So drugs like loperamide, right, are useful because they prevent diarrhea. These drugs are also useful if the some event, something like that, right, and you can't that morning can also something like loperamide, they will not go to the toilet. But we don't generally encourage long-term use, right, of these drugs. The same way, if it is constipation predominant, you can use a laxative, right? You can use a laxative, right? And you would have had lectures on the different types of laxatives and so on. Now you find that some patients are anxious, right? Some patients are anxious and their IBS is related to anxiety, right? So for those patients, right, what you need to do is you need to give them anxiolytics, right? For anxiety, give anxiolytics, right? These drugs like alprazolam, like Librium, and so on, right? Then, if you find that they are depressed, right? Because that is more likely to cause constipation, sort of predominant IBS. If they have depression, then of course you have to give them antidepressants. Right? Another important area in the management of these patients is psychotherapy, right? And I can remember even when we were students, right? The psychiatry unit, they treat patients as day cases, where the patient comes in the morning and goes in the evening without having to get admitted, right? And they were treating these patients, right, with psychotherapy. I don't know if they are doing it now, right? But psychotherapy also is useful, right? Psychotherapy is also useful because, like I said, there is a psychological component in this disease. Right? So this is a slide which shows, we are moving on to IBD, inflammatory bowel disease. This is a slide that shows you the complex mechanisms that take place in IBD, but essentially, right, no one has really found a cause for inflammatory bowel disease, right? Very often patients ask us, right, what is the cause? Why did I get this? What is the cause of this disease? And we can't really give a cause except to say that it is a immunological mechanism. Now, in ulcerative colitis, I think you would have had lectures on this. You get bleeding per rectum or a blood and mucus diarrhea, and that is usually the start of this disease. And it is a disease that usually starts in the rectum and then spreads upwards, right? So most of the patients start with an acute colitis, right? They start with acute colitis and then they have exacerbations and remissions. Now, ulcerative colitis and Crohn's is a little different, right? In the part of the large bowel that they affect, like I said, ulcerative colitis starts in the rectum and goes upwards, right? And you find that majority of our patients actually have what is called a left-sided colitis, right? Sometimes it's only a proctitis, right? Sometimes only in this region, right? Or they have a left-sided colitis going up to about that, right? Okay, so that is this part of the colon is called the left colon, right? Because it's situated on the left side of the abdomen, right? So they have a left colitis. But there are also, we have quite a few patients who have a what is called a total proctocolitis, right? So procto refers to rectum, right? We say proctoscopy, right? We don't say rectoscopy. So, so that would of course involve the entire large bowel, right? Another interesting feature of this disease, ulcerative colitis, is that it is a disease that affects only the large bowel, right? It affects only the large bowel. The older books, of course, will talk about a thing called backwash ileitis, where they think that, you get like a backwash, to this ileum here, but actually that is not so. Maybe those patients were actually patients who had Crohn's disease, because Crohn's disease is a disease that can affect any part of the gastrointestinal system from the mouth to the anus, right? But there are common areas. Now, this is a common area, the ileocecal region, right? You can also get it in other areas, and you can get strictures like this, right? The second most common area is the perianal region, and you find these patients having multiple anal fissures or multiple anal fistulae or multiple perianal abscesses, right? They have combinations of all these things. Now, how do we diagnose, right? Now, ulcerative colitis, because it starts in the rectum and spreads upwards, right? It can be diagnosed by sigmoidoscopy, right? In fact, in our medical student days, right, they used to diagnose this with a rigid sigmoidoscopy. You see a beefy red mucosa, right? But now we have flexible sigmoidoscopy. And especially if you have an acute colitis, right? If you, for example, patient having severe blood and mucus diarrhea, right? The best thing to do at that point, right? And if you suspect ulcerative colitis, would be to do a sigmoidoscopy. The reason is that if you do a colonoscopy, right? Because there is close inflammation of the bowel wall, there is a risk of perforation, right? Now, even with normal colonoscopies, right? Maybe about 1 in 10,000, right? You have a risk of perforation, right? Now, when they have ulcerative colitis, that risk becomes greater, right? But so initially, you might just do a sigmoidoscopy, right? And then take biopsies, confirm the diagnosis, and then after confirming the diagnosis, you start the patient on treatment. And once the patient starts going into remission, then you can do a total colonoscopy, right? You can do a total colonoscopy, and when you do this colonoscopy, it's very important to take biopsies even from areas that may look normal to you, right? So we take a biopsy series, right, from the right colon, from the transverse colon, right? Descending colon, sigmoid colon, rectum, and so on. Right? Then, of course, you have barium enema, right? You have barium enema. Now, barium enema, of course, is not very much used nowadays, right? Okay, it's not very much used nowadays, but there are some characteristic features, right, that you may get on a barium enema, which I will show you if the patient has ulcerative colitis. Then, of course, we do full blood count, ESR and CRP. This is actually not to diagnose, but this is to monitor the progress. A lot of these patients are found to be anemic, right? And then with treatment, the anemia improves. Many of them also have elevations of ESR, and actually CRP is the most sensitive test to see the activity of the disease. Yes, so this, if you look at this slide, right, this is showing you barium enema. And you know that the large bowel usually has hostrations, right? They are secular hostrations. But in these patients, because of the inflammation that has gone on for some time, the hostrations are absent, right? So this is called the shapeless bowel of ulcerative colitis, right? Because normally ulcerative colitis bowel, the normal bowel, right, has a kind of a shape. Here are some pictures, right, of inflammation in UC, right? So this is moderate inflammation, and this is this is the normal mucosa, right? So this one is the normal mucosa, right? The normal colonic mucosa. If you look here, you have mild inflammation. There is some erythema. Then here you have more erythema and little bit of ulceration, and then this is severe ulcerative colitis, right? Where the almost the entire mucosa is angry looking, right? It is inflamed, right? Okay. And this is of course a diagram, a picture of a bowel that has been dissected. Okay. Now, what about the treatment of this condition? Now, if a patient has ulcerative colitis, right, you start with treatment of this acute colitis. And the acute colitis treatment is usually steroids, because there are two steps, right, in the management of these patients. First, now the patient is having a colitis, you want to induce remission, right? And then you want to maintain the patient in remission. So induction of remission can be done with steroids, right? Prednisolone. Right? And the general principle is you start with a high dose, right? You start with a very high dose, like 40 milligrams a day, and then you gradually reduce and tail it off over the 3 months. But along with that, you will need to also start one of the disease-modifying drugs, right, to maintain remission, right? And the drug that is available in the hospital is sulfasalazine, also called salazapine, that is available in all government hospitals, right? But this drug is actually a combination of 5-amino salicylic acid and sulfur. So there are some patients who cannot tolerate the sulfur component. They are allergic to sulfur, right? So for those people, you need to give the PO5-ASA derivative, right, which is called mesalazine. And then, of course, if you find that the disease is confined to the rectum, right, then you can try prednisolone or hydrocortisone enemas, right? You can try prednisolone or hydrocortisone enemas, right? Just 1 minute, please. Right. Okay. Now we move on to complications of ulcerative colitis. Now, some patients can go into what is called toxic megacolon, right? Where you have very severe inflammation, right? With a risk of perforation, right? And classically, you will see air when you do an X-ray, right? You can actually see air in the wall. Now, we all know there is air in the lumen of the gut, right? But you can see air in the wall of the little air bubbles, right? In the wall of the colon, right? So it's a very, and in this situation, patients are very, very ill. They have very high fever, right? Very ill looking, dehydrated, right? Septic, right? And if you don't intervene and remove the colon, right, very quickly, then the colon, and if you don't remove the colon very quickly, then the patient is going to die, right? So it's a fairly serious condition. Fortunately, right, in our country, we don't see much of it. The reason is I told you a lot of our patients actually have left-sided colitis, right? This condition you get in patients who have the entire colon, right, involved with ulcerative colitis. And when the entire colon is involved with ulcerative colitis, it is called pan-proctocolitis, right? Then you have perforation, right? So perforations can occur spontaneously, like due to a toxic megacolon, or a perforation could occur in these patients during a colonoscopy. Then you can also get abscess formation, paracolic abscess formation, right? You can get peritonitis, right? Inflammation, and also and if you have ulcerative colitis going on for a long period, several decades, right? These patients can develop adenocarcinomas. And because the tumor starts in the rectum and spreads upwards later, you find that very often the carcinoma occurs in the rectum. And before that, patients go through dysplasia, right? So you have ulcerative colitis, then you have mild, moderate, and severe dysplasia, and then it becomes carcinoma in situ. And then when the tumor invades the basement membrane, it becomes an adenocarcinoma. Now, that I discussed with you the medical treatment, right, for ulcerative colitis, but there are some patients who require surgery. And the surgery involves removing the entire colon and the rectum. So this is not a condition where you can remove part of it, right? You have to remove the entire colon and the rectum. And anyway, by the time you get to doing surgery, very often the patient has a pan-proctocolitis. So there is inflammation in the entire colon and rectum. If you remove part of it, right, then later the other part will also get the same problem. Right? So you need to remove the entire colon and rectum. And then when you remove that, right, you are left with two options. One is you can have an endoileostomy, right? And that in the days gone by, that is what they did, right? You put an endoileostomy. Or you can do what is called a ileal pouch anal anastomosis. Now, if you just, now you have removed the entire colon has been removed. If you just anastomose the ileum to the anal canal, you can imagine what will happen, right? The patient will be living in the toilet, right? Because you know that the small bowel, right, puts out many liters of liquid, right, into the large bowel, and it is the large bowel, the colon, that absorbs all the water, right? So this patient will be then pouring out stools, So that is the thing. Then right, so that is a problem. Then of course you have what is called poor compliance, right? So right. Then, so that is one. So therefore, you need to do a. So if you just do an anastomosis, right? This patient is going to pour out stools. So therefore, we do what is called a ileal pouch, right? And you can see this. Basically, what is done is the ileum is folded on itself to make a pouch, and that increases the absorptive surface, right? And so that the patient will not, have to go to the toilet many times, right? And then this ileal pouch is anastomosed to the anal canal, and that is called ileal pouch anal anastomosis. So this is useful for younger patients, right, who are not responding to medical treatment, right? Some people who are poorly compliant, they just tell you, I can't take this medicine every day. People who are getting side effects, right, to these medications, right? And also, if the person has severe dysplasia, right, say these patients with ulcerative colitis need serial colonoscopies, right? After the now in the first like 10 years, because these are chronic disorder, right? And one important thing that you need to tell these patients is that their treatment, if they are going on medical treatment, treatment will have to be lifelong, right? You can't stop the treatment. And I told you what the treatment is, the 5-ASA derivatives, right? Either mesalazine or sulfasalazine, they have to take it lifelong. So there are some patients who say that they can't take medicines like that. There are some who develop side effects, right, with the medicines. So those are all indications for surgery. The other thing is that these patients need to be on surveillance, right? So once in about 2 to 3 years, you need to do a colonoscopy on them, even if they are asymptomatic, right? And then after about, say about, after they've had it for about 20, 30 years, you will have to do annual colonoscopies and biopsies. And when we do these colonoscopies, we do serial biopsies from different parts of the colon. Now, if these biopsies start showing dysplasia, right, and especially if there is severe dysplasia, then you know that the next stage is that he is going to develop a adenocarcinoma, right? So therefore, in those patients also, surgery needs to be done. The colon has to be taken out, and then possibly a pouch has to be made. Now, moving on to Crohn's disease, the presentation is a little different. You have this triad, right, of loose stools, abdominal pain. I wouldn't say right iliac fossa pain because we don't, because it depends on where the problem is. Yes, commonly it's right iliac fossa pain, right, but abdominal pain and weight loss, right? So this combination, if you have loose stools, abdominal pain and weight loss, in a young patient, right, you start thinking of the possibility of Crohn's disease. The other presentation is the multiple anal fistulae, not just fistulae, they have fissures, right? They have perianal abscesses, right? And if you look at that area, right, perianal area, it is, you find that it is not a very pleasant sight in these patients. Right, now, how do we diagnose? Colonoscopy, right? Again, up to the terminal ileum, you can see in colonoscopy. You don't have that, you can do a barium enema, right, which might show strictures. But because this disease, right, involves now if you diagnose, right, this in the colon, right, or in the terminal ileum, then you also need to check the other areas of the gastrointestinal system. So the patient needs an upper GI endoscopy, and then sometimes a capsule enteroscopy, because now to look at the small bowel, right, the investigation of choice, if you have the facilities, is what is called a capsule enteroscopy. So this capsule, you would have heard about this, right? It's basically a camera, right, which is put into a capsule, right, which has been fitted into a capsule, right, which can be swallowed by the patient, right? And then when the patient swallows it, the capsule passes through the entire gastrointestinal system, right, and ultimately goes out from the anus. And while it travels, it transmits images in the form of like a film, right? And then, of course, it is about 4 or 5 hours of film, sometimes even longer, right? And you have to then sit and go through this film, right, to see where the problem is. The only thing capsule enteroscopy can diagnose Crohn's disease, right, on the appearance, on the mucosal appearance, but unfortunately, you cannot take biopsies, right? So therefore, you may need a enteroscopy, right? So there is a thing called the push enteroscope and another one called the double balloon enteroscope, right? Basically, these are long instruments, much longer than your colonoscope, right? About more than 2 meters long. And with this enteroscope, right, you can visualize the small bowel. Now, there are some other tests also that we do to assess the activity of the disease, right? So if you do ESR and CRP, particularly CRP, it gives you an idea of the activity of the disease, and also if you do the CRP before treatment, right? And then during treatment, you can see whether there has been a response, right? You can see that without doing another colonoscopy. So these are some pictures, right, of ulcers that you get in Crohn's disease, right? You get these little aphthous ulcers like things, right, in Crohn's disease. And here in this patient, there is deep ulceration, right? You can see deep ulceration in the sigmoid colon. But ultimately, it is the histology that gives you the diagnosis. What is this? This is ulcerative colitis with pseudopolyps, right? Ulcerative colitis with pseudopolyps. Pseudopolyps are actually areas of regenerated mucosa, right? Pseudopolyps are much less common in Crohn's disease. They are more common in ulcerative colitis. And if you look at this, right, if you look at this picture, you can see what it looks like, and you can identify these pseudopolyps. The other feature that you will see in this is, unlike a person who is just having a lot of polyps, you find that the surrounding areas, right, are also inflamed, right? There are inflamed areas to be seen. So what about the treatment of Crohn's disease? We have steroids, right? Uh, right, which is commonly used for treatment, right? And again, we don't go for lifelong treatment, right? You treat for a few months, right? And then see the response, right? Then there is also certain disease-modifying drugs like azathioprine, right? You can use azathioprine. Actually, it's an immunosuppressive, right? It's an immunosuppressive drug. Azathioprine is also used in Crohn's disease. Cyclosporins are the drugs that can be used. And of course, now we have this infliximab, which is an antibody to tumor necrosis factor. Now, in addition to infliximab, right, there are various other drugs, right, like adalimumab, right, ustrophizumab, and so on, right, which can be used in the treatment of intractable Crohn's disease. These drugs can be used both in ulcerative colitis as well as in Crohn's disease, right? What about complications of Crohn's? You can get fistulation, right? Now, I told you about the spontaneous perianal fistulae. Now, following surgery, let us say if you do now Crohn's causes strictures, right? Crohn's causes strictures. Sometimes you need to resect that part, right? If it's a very bad stricture. But commonly what is done is a stricturoplasty, where you can actually increase the caliber, right, at that site. Right? You can increase the size of the lumen. But after these operations also, patients can develop anal fistulae. Fistulae can be internal, for example, between bowel loops, between the small bowel and the large bowel, or between the small bowel and the bladder, and so on. So those are called internal fistulae. And of course, after surgery, you can get external fistulae. You can also get perforation because it causes strictures, right? And then the proximal bowel can dilate and you can get perforations. You can get severe perianal disease. And now we talked about ulcerative colitis and malignancy. Crohn's disease has a lower malignant potential, right? So with Crohn's, you are less likely to develop malignancy when compared to ulcerative colitis, right? Now, sometimes because Crohn's commonly affects the ileocecal region, right? Sometimes you wonder whether this is Crohn's or tuberculosis, because tuberculosis is also a disease which is prevalent in this part of the world, right? And we must remember that probably TB is still commoner as a disease, though TB in the gut is not that common. So sometimes these presentations are these diseases are very similar. And then even when you do colonoscopy, you can't decide, right, whether this is TB or Crohn's. Sometimes histology helps, but the only problem is that to diagnose TB, you need to really demonstrate a caseating granuloma, right? And in these little biopsies that you take, right, it's difficult to demonstrate a caseating granuloma. So sometimes you have a dilemma as to whether to treat for TB or whether to treat for Crohn's disease. In that situation, right, it is better to treat for TB, because for TB, with the anti-TB drugs, Crohn's disease will not worsen. But if you give steroids by mistake to a patient with TB, thinking that it is Crohn's disease, then you know that with the steroids and immunosuppression, the TB can spread. You can even end up with miliary TB. Right? So TB now we know that lung TB is treated for 6 months, right? If you have TB in the bowel, right, then you have to treat it for 9 months. Okay? Then, of course, at the beginning, I told you about those infective chronic diarrheas like amoebiasis and giardiasis. In those, what we do is we analyze the stools, right? We do a good stools full report, right? And then you can identify In the case of the MEB, you can get, you might see the cyst, right? Or the live MEB if you examine a fresh specimen, right? And giardia also can be identified on stool microscopy, right? You can also do stools for culture, right? You can also do stools for culture. It is difficult to culture these organisms, right? But there are certain other organisms that you might be able to culture, like salmonella and so on, right? So that's about all, right? That I have to tell you about chronic diarrheas. Any questions, anything that you want to ask me? Okay, then in the absence of questions, thank you. Thank you very much.
Thank you, sir.